All right, so now let's look at SVT. Which is supraventricular tachycardia. Nope, not that. Okay, so if you look at just the word of SVT, you would see supra, above, ventricle, above the ventricle, tachycardia, above 100. Okay, so we have something going on above the ventricles, which would be the atria, and it's a tachycardic rhythm. Okay, so looking at this rhythm that I have down here, what do you see? Well, what's the first thing? Where's my P waves? P waves? Yeah. But looks like they're buried in there because it's going so fast that it's bunched up in there, right? Okay, so yeah, we see them. Okay. Now, what about my QRS? What's the thickness we're working on here? Pretty thin, right? So now I'm thinking, okay, this is something above the ventricles. Because remember, ventricles, above them, it's going to be thin. Below them, it's going to be fat and wide. Look at VTAC. Okay, so now they're pretty thin. Now, what about my R to R? Are they normally spaced out? Okay, so I check. I put my first tick mark, my second tick mark on my piece of paper, and then I move these two over to this one. Yeah. Yeah, we look pretty paced out here. Okay, so we have a regular rhythm. We have P waves, and they're thin. Well, just by this right here, we've ruled out a ventricular arrhythmia. We've also ruled out AFib, right? Because it's regular. If it wasn't regular, we'd be looking at AFib. So it's not ventricle, and it's not AFib. And I have P waves as well. They're in there. Okay, so now SVT is like an umbrella, and it oversees 3 categories. Now, the main one that I'll just talk about is basically the one that can get stuck in the AV node. So if we have this is a close-up of my AV node. Okay, and I have 2 pathways in the AV node. I have one, and it's called my slow pathway. And I have another one, and this is my fast pathway right here. Okay, and so when a signal comes in, it can go one of these. Okay, but here's the problem, is that if a signal needs to come in, and let's say we send it down here, down the slow channel, and the signal travels down, it can accidentally get shot up here. And now we can go counterclockwise and back up into the atria. So if I'm stuck here, I'm going to start sending signals back out. And the signals are going to be coming in. And I'm going to be sending signals back out. And what we do is we get this re-entry loop here. And we keep doing this, and this, and this. And some are getting sent out, and we're getting them sent up. So we're getting this loop of stimuluses, and they're just stuck in that AV node right there. So now if we're sitting here and we're stuck, we're going to be sending a lot of discharges, the ones that are getting through and sent down to the ventricles. Well, SVT is characterized as anything greater than 150 beats per minute. Okay, so if we walk in and Grandma's sitting on the couch and has been watching Jeopardy and she has a heart rate of 150, we're going to start thinking SVT on this patient. Okay, so now if we're stuck in that pathway and we're making our loop here, what is the drug that we can give that is the number one treatment for SVT? And that drug is adenosine. Remember? That's the one. That's the one that works on the AV node right there. So we come over here and we're like, okay, let's give you some adenosine. Well, on a cellular level, is it makes potassium leave the cell and it hyperpolarizes the cell. Basically, it means that it makes the cell very negative. It also inhibits calcium channels, and the calcium channels can't come in, which mainly the L type. The L type is the one that floods the cell with calcium, and that's the one that gets to that point of our threshold to where we can discharge. And it's also, it decreases conduction velocity. However, what it does is that it'll cause a AV block when we give it, and it'll last for a few seconds. So basically, it just shuts off in here. So these impulses are trying to come in. We have an AV block. We need to do a total reset of this AV node, right? Especially when I was talking about that one that loops, and we got this coming in, and then we end up circling. Well, if we did a total reset and said, stop it. Well, now we can carry on business as normal. We can take my impulse again, because we just knocked out that re-entrant conduction that was going on. Now we fixed it. Here's the thing, though, with adenosine, and this is important to know, is that when you give adenosine, it has a half-life of seconds. So it's extremely short-acting. Extremely. Because remember how I was saying, we're causing high-grade AV block for a few seconds. Can you imagine if we had a half-life of 5 minutes? We'd be doing CPR on this guy. Okay, so we're going to be doing a half-life of seconds. Nope. Another thing that you want to do, you want to pit the IV the closest to the heart. So on this patient, you're not going to want to be doing an IV in their toe, in their leg, in their ankle. You're going to want to be doing this in a vein that, one, can withhold the pressure, because the next procedure requires a lot of pressure, and we're going to have it closest to the heart. My favorite go-to spot on these patients was an antecubital, the crook of the arm. You know, as patients say it, in my elbow. That's the good spot to go to. I liked going into the, right or left, AC, we pop it in, and now our access is going to be into the arm and right down into the right atrium, and then it's going to hit that AV node, right? Because if I have seconds and I send it from the legs, the med's going to be less potent because it's already crossed 4 countries in order to get to the heart. So that's a huge one right there. Another one that if you're not ready for it, it'll scare you and your patient. They're going to flatline for a second. They're going to take a pause. They're going to have a heart pause. So if you look back up at my EKG or my heart monitor that I have here, and I'm going boom, boom, I am flying, right? Now, when I give this med, and let's say I'm going to give it, that was another thing, administration. So when you go to give this, because the half-life is so short, you are going to give, this is a 2-person job, one person is going to be giving the med, and another person is going to have a 20 ml flush with saline or the lactating ringer, whatever crystalloid that the patient is already getting, because this patient's already going to be receiving IV fluids. So 1 to 2 people are going to be giving, 2 people to give this med. So what happens is that if we have the patient's arm, okay, and I have my IV here, I am going to be giving my adenosine. Now, another person who may be on the IV bag is going to be a little bit higher than me, and they're going to be giving the flush. Here's the thing, though. You have to clamp down on that IV above where you're going to flush. Because if you don't clamp down on that IV tubing, and I push that flush, or even the guy who's giving the adenosine, if you don't clamp down on that and push it in, you'll have backflow. On the tubing that we had, we always had to clamp it before we sent it. So I'm going to be clamped. I'm going to send it. As soon as that's flying in, and I mean rapid push, you're giving it as fast as you possibly can. Once you're giving it, your flush guy is going to send that 20 ml flush as hard as they can, and it's going to send it through, and it's going to push that med up, and we're going to get it, and we're going to dump it right into here. And we're going to hit that AV node. We're going to cause that block. Now, when I was talking about the things that'll scare you or your patient, is that if you're not ready for it, and you give this med, and it lands, it comes in, it can land anywhere in there, but I'm going to say where the blue line is where the adenosine starts. You're going to get a pause. So you'll have you'll have your SVT, and then you'll just get this pause right there that looks flatlined. And I mean, it is super scary watching this thing, praying to God that it restarts and we can get another QRS out of it. So when this patient comes out and we get a restart, we should hopefully have converted them and they'll go into a normal. Well, the protocol is for your first dose is 6 milligrams. Then, if they're refractory to it, so the 6 milligrams did not help, and they're still in SVT, now we're going to give 12 milligrams to this patient. Okay, so we're just going to double the dose. You're going to do the same thing. You're going to have somebody who pushes for you, and you're going to line up the patient and make sure that you teach this patient too of what they're going to feel like. Because when you take a roller coaster and you get up to that really high point and it drops really fast and it feels like your heart just flip-flopped, like it felt like your heart stopped, that's what it's going to feel for them. And then they're going to basically be in a pause. It's the scariest thing ever. It freaks them out every single time, as I would be too. So that's a huge one to do for patient education on this person. But the first line treatment for this patient, the first thing you start off with is a vagal maneuver. And what you do is, oh, that was supposed to be a star. And this is first thing you do right here. You're basically going to have them bear down as hard as you can. So I always told my patients, bear down like you're taking one of the hardest poops of your life. And we're going to try to get them to vagal themselves out of this rhythm. So you have them bear down as hard as they can, pretend like you're taking a poop from me, or we give them one of our syringes, like a 5 ml or 10 ml syringe. We pull the stopcock back just a little bit, give it to them, say, put this in your mouth and blow on this, and try to blow the plunger back as hard as you can, and that'll try to trigger that vagal. Another thing, like Dur was saying, is you can do the ice water. That was something that we used to do for kids, is we'd get the ice water and put their faces in it, and that hopefully will stimulate the vagal. Another thing that you can do, and it's not really recommended, is you can do a carotid massage. So what you do is you go and you put your fingers on the carotid and you massage the carotid in hopes that it will then cause decreased stimulation and hopefully lower their heart rate. But the problem is that we don't know where they are currently at with their carotids having plaque. And so if we have our carotid and we get an old lady and she's got nice and plaqued carotids, right? because we didn't listen for a bruit on this patient, and we go over there and massage that, we could break this off, one of these off the side, and send it in to the bloodstream. And now we caused our patient pulmonary embolism, stroke, all these things. So a carotid massage is not really recommended for this person. But that is something else you could do. But just remember, first line treatment. Your patient comes into the hospital. He's like, yeah, I got shortness of breath. I'm sitting at 150 or 180 beats per minute. He has this rhythm that's shown above. You're like, okay, this is SVT. Come with us. Also, when you get you into bed, bear down like you're taking a dump. You let him bear down, you bear down, you have him on the monitor, you're watching, and you're seeing for the conversion or the slope, to convert. Nothing then we're going to start going to our adenosine. Okay, those are our two go-tos right there. Another thing we can do, just like we were talking about, is a sync cardioversion. And I was talking about that earlier, is we can cardiovert them. We can shock them. Now this one doesn't take a lot of joules, which is the nice thing. Another treatment we can do is we can do, obviously, our beta blockers, calcium channel blockers, digoxin again. Remember, because it goes to the AV node as well. It also gives us a good force of contraction. We can do our amio. That's pretty much it for that. We just want to make sure to watch these patients. The biggest thing is you do a vagal first, then adenosine. And the big thing about adenosine, you want an IV that's closest to the heart. You're going to want to know that there's going to be a possible flat line coming, a pause. You want to notify your patient that pause is coming. So that way, when you give it, and you haven't told them, and the next thing you know, they're like, Jesus Christ, I'm dying. That we've already preemptively told them, it's going to feel like your heart did a flip-flop. Okay? Those are your big things for SVT.